everyone. My name is Kathy. I'm a student SRNA from Western Carolina University, and I'll be talking about operating room emergencies today. You may have noticed there's two different attachments. There's the PowerPoint, which is pretty much the book in PowerPoint form, and then there's also just a two-page front and back cheat sheet. So when you're really going to study, this is more the bare bones of what you need to know. Looking at how many questions are coming from this section, I don't think that this is a spot that you should spend a lot of time on. There's only 5 questions from all of these slides. So that's why I think if you just study the high points, you should be good to go. So we'll start off by talking about airway emergencies, which is kind of your bread and butter. You guys are always the ones that are the resources when it comes to these. This is just the ASA difficult airway management guidelines. It's not necessarily the rules absolute, it's recommendations, and we'll go into that a little bit more. The way the book breaks it down is by different steps. So the first step is just evaluating the patient before you've done anything to them. Do they look like they're going to be a difficult mask ventilation, or are they going to be a difficult intubation, just on specific factors? So difficult mask ventilation factors. It's kind of like this Father Christmas. Do they have a beard? Are they rather large? No teeth and history of sleep apnea. Most likely, they're going to be difficult to mask ventilate. Versus difficult intubation, they might have small mouth opening. They don't open very wide. They have a really big tongue. They can't extend their neck back very well. And it's kind of like when they push their mandible forward, it's like a bulldog. They can't look like a bulldog. And if, obviously, they've had a difficult intubation history in the past. There are lots of other factors that can make difficult intubations or difficult ventilation. Infection, if you have a big mass right here full of pus, you're afraid that you might pop it. A tumor might change the anatomy a lot. If they've had surgery or if they've had radiation, again, those are going to change your anatomy quite a bit. So now we've determined that they're difficult intubation or ventilation. What are we going to do next? Well, we're going to give them oxygen. And something that they found is if you put a nasal cannula on while you're trying to mask them, like if you're trying to intubate and you've gone again and again and they're not getting oxygen because people are in the airway, they found that passive allowance of oxygen actually benefits the patient and they won't desat as quickly. Clearly they're not ventilating, but that passive oxygenation, they might still have some brain function if it's a really truly emergency situation. Always pre-oxygenate. I know that's something that we kind of get away from, especially in a fast-paced setting. So now we're going to actually look at the airway management. Are we going to do this as awake, or are we going to go to sleep? A 2-year-old who is going to be a difficult intubation is probably not going to be super cooperative for an awake intubation. Do we need to have a surgeon nearby for a surgical airway, or do we need to maybe get the gyroscope, retrograde wire intubation, or a fiber optic bronch? And then, do I want to paralyze them? That's definitely going down a road that we can't necessarily get back from very quickly. We could use succinylcholine, which is that depolarizing agent that wears off very quickly. But if you were to give a non-depolarizer like vecuronium or rocuronium, you've gone down a path and you're not going to have any ability for the patient to even try to make a spontaneous breath for at least 30 minutes to an hour and a half. So this is just the difficult airway algorithm kind of blown up. You can see here, if you're unsuccessful on your first attempt of intubation, you either try to face mask with ventilation, or if your ventilation is not adequate. If your ventilation is adequate with a face mask, it is no longer considered to be an emergency situation. As long as you're able to ventilate, it is not an emergency. However, if it is not adequate, you would go down this other pathway. Can you put in an LMA? Is that adequate? Again, we're back to non-emergency. If it is truly an emergency situation, we're looking for either doing a cricothyrotomy, getting a surgeon in, or wake a patient patient back up. Those are all different options. And like I just said, if you can mask ventilate, it is truly not an emergency. I think what actually becomes an emergency is when you can mask ventilate and you keep doing the same thing over and over again, the MAC3 blade, but different people using the MAC3 blade, chances are you're going to cause some swelling, and over time, you're going to create an emergency and an unable to ventilate situation. So what can we do? Oral airways, nasal airways, having someone hold the bag with mask with two hands and someone squeeze the bag. Using the LMA or a combo tube, which is more for like an EMS situation. So I've thrown in some pop quiz questions, and this is the first one. I'll give you a moment to read it over. The predictor of difficult mask ventilation. Brad, you want to take a guess?
Just the beer?
Mm-hmm. Exactly. Small mouth opening, difficult intubation. Prominent front teeth, probably difficult intubation. Elderly is more of a distractor. So the beard, exactly. This is more just an image of what a combo tube looks like, because I don't think I've ever seen one in the operative setting. Have you ever used one?
We have.
You have?
Yes.
Did it go well?
Yes.
Nice. Why did you use it? I'm just curious.
They asked, we delivered.
So you can't actually intubate with one of these, but they'll use them a lot in EMS type situations. You can just insert it blindly, it goes in, and there's two holes there, so regardless of what hole you put it in, the esophagus or the trachea, it's going to work, which is really nice. I threw this in because it's in the book, but transtracheal jet ventilation would be if you were going to do a cricothyrotomy and you have just a really small, like a 14 gauge catheter sticking out of it to deliver oxygen. Most importantly, is you want to watch for the rise and fall of the chest rather than concentrate on all the vent settings. Obviously, those are important too, but chest rise and fall is your end goal. This is the kit that you guys have here, the cricothyrotomy catheter set. And inside, you can see the needle to make the first initial incision with, the guide wire. You have the obturator here, and what you're hopefully eventually going to put in right there. In a couple of slides, you'll see I have some YouTube videos, and so there's a few different options. You can look at them, but I figured on your own time if you're interested, just to kind of get an idea of what pieces go at what point. The most important thing is you want to stay midline. It's a really vascular area. If you were to make a horizontal incision instead of a vertical incision, you could cause some significant bleeding. This is all obviously going to be a very high stress situation because not many people have done one of these, and it's in a dire situation that you're doing it. If you don't have a kit, you can always use a scalpel and an endotracheal tube. And there were a lot of different creative solutions if you don't have a jet ventilator on the internet. I'm not sure how reliable all of those were, but they seem to have worked for them. And so these are the ones you can watch on your own time. Emergency crag, I believe, is just the endotracheal tube with a scalpel, and the Seldinger cricothyrotomy is the one that uses the kit that you guys have. So another pop quiz. How would you guys consider securing this person's airway? It looks like their neck is mostly intact.
You've got to tube them.
You gotta do them.
Then I guess just try the MAC3 first.
I would probably go with the cricothyrotomy for this. This one's more, I think, very subjective. Obviously, you could probably do this a few different ways. The MAC3, I have a feeling if you were to go in there and just do a regular DL, you would just be blood and tissue and maybe just sections of tissue. Mass ventilating is probably not going to work so well. The intubating LMA, again, getting into the mouth doesn't seem like a realistic option. And so you can't really see his neck in this picture, so it's a bit of a trick question. But I think just going straight to like a cricothyrotomy or a surgical airway is going to be the one that you're going to want to do for this person. So I'll go into a couple of disease processes. One is epiglottitis, infection of the epiglottis. It happens more often in the pediatric population, and they'll come in kind of hunched over in like a tripod type sitting position because there's a huge obstruction right here. This is a patient you don't want to upset. You don't want to take them from mom as soon as possible. You want to make sure that they're calm because as soon as they get excited, they're going to lose their airway. Fiber optic technique would be a really great way to secure this person's airway. Infection around the neck, jaw, or the back of the throat can make things really challenging. Again, there could be a pus-filled pocket back there that you could accidentally hit while intubating. There could be a lot of swelling, distorting all of the tissue. And it could also just, you might not find the vocal cords. There might be something in the way. Laryngospasm occurs when the patient is not intubated. If they had an endotracheal tube in, they could still laryngospasm, but it won't be clinically significant because there's a tube securing your airway. And that's just spastic closure of your vocal cords causing an obstruction. Again, most often occurring in the pediatric population, occurring when, usually between induction and emergence, those are your two times, and that's because you're at a lighter anesthetic level. And that's when you're more sensitive and more likely to have stimulation of the pharynx causing the laryngospasm. So ways to treat this: stop stimulating the patient. When you're trying to slide the pediatric patient over while they're in stage 2 over to the bed is probably not the best time to try and move them. To break an active laryngospasm, using positive pressure with a face mask, deepening the anesthetic, giving more propofol, and in a case where you really can't move air, propofol didn't work, go straight to sucks, either IM or IV, depending on if you have an IV or not. So that was your airway management. Move on to cardiac arrest. And again, most of this information is from the book. I did pull in some extra information, but not a whole lot. And I think that this guide will really help. The only thing that I included on this sheet that is not in here in the PowerPoint are the H's and T's, which comes from ACLS guidelines. And I think this is more just good to think about when you do have an existing cardiac arrest event, rather than things that you need to necessarily memorize. I would be just familiar with them, but they all kind of make sense. So a cardiac arrest happens when the heart cannot provide sufficient blood flow because of either lack of electrical or mechanical activity or both. So what are you guys going to do? Get the crash cart there, getting the defibrillator pads on. I feel like you guys are the organizing movement for a really high-tense situation like this. Making sure if they're on a bed, getting a backboard under them to provide adequate chest compressions. Making sure that they have oxygen. And then with any type of cardiac arrest, there's always going to be 100 people in the room, and only 5 of them really need to be there. So you guys are also the gatekeepers. Like, do you need to make sure people are leaving appropriately? The 10 people who are on the side of the wall who are just watching, do they really need to be there? They're just kind of making it more difficult. And then what kind of vascular access do they have? Do we need to set up? And what kind of transport do we need to set up? Are they going to the ICU? Are they stable enough to go to the ICU? So with a cardiac arrest, your initial response is chest compressions. This is new ACLS guidelines. You start with chest compressions. It used to be ABC, and now it's CAB. Chest compressions always come first. Get the defibrillator pads on as fast as possible. Sometimes you'll have them on ahead of time because you kind of see this coming. Sometimes it's a complete surprise, which again is why you would go straight to the chest compressions. Make sure the anesthesia gases are turned off and give oxygen. This is just an algorithm of ACLS. So are they unresponsive? Are they not breathing? They used to say to check for a carotid pulse for longer. At this point, I think it's maybe 6 seconds or 6 to 10 seconds that you're allowed to check for a pulse. If at that point you can't feel anything, you're supposed to go straight to chest compressions. But I think it's mostly at this point, are they unresponsive? Are they not breathing? Just go straight to chest compressions. Once you get a defibrillator there, it's important to go ahead and get that set up. If it's one of the ones that are out in the community site, it's going to tell you versus here in the hospital where you have to decide when to shock. You're going to do a pulse check. every 2 minutes after the defibrillator has actually done its job. CPR to oxygen is a 30-to-2 ratio, so 30 chest compressions to 2 breaths. After 2-minute cycles, you check the rhythm. If not, you go back to shocking again if it's a shockable rhythm. Shockable rhythms would be like ventricular fibrillation, ventricular tachycardia. Asystole is not a shockable rhythm. In the meantime, you're also giving drug therapy. Epinephrine, amiodarone, vasopressin, maybe atropine, and then treat reversible causes. Those are the H's and T's that are on the other sheet. And those include hypovolemia, hypoxia, hypothermia, hypoglycemia, maybe they have a cardiac tamponade, maybe it's just trauma, or thrombosis. These are just some of them. So I included some drugs. I know that you guys had another lecture for drugs. This is just kind of a recap. So epinephrine is going to be an alpha-1, beta-1, beta-2 stimulant. It's an agonist at those sites. Beta-1, you have one heart. It's going to increase your heart rate and contractility. Beta-2, you have 2 lungs. That's how I remember what beta-1 versus beta-2 is going to affect. And that's going to affect your smooth muscle of the bronchial tissue. And it's going to relax it. So a beta-2 agonist, pure beta-2 agonist, would be like albuterol. A pure beta-1 agonist would be like isoproterenol. And then alpha-1 is going to increase your afterload by squeezing your vascular beds. Something like neosynephrine would be an alpha-1 agonist. Epinephrine gets to do all of them. So in a code situation, you're giving 1 milligram every 3 minutes. And that's the 1 to 10,000 concentration. And that's the 1 milligram in the cardiac that's in our hearts. And this will hopefully improve coronary perfusion. Instead of using epinephrine for the first or the second dose, you could use vasopressin, 40 units. And vasopressin is a really unique drug. It's also something that's naturally found in our body like epinephrine is. It comes from the posterior pituitary gland, right underneath the hypothalamus. And it's released because of hyperosmolarity, so you don't have enough water in your body, or hypovolemia, you don't have enough blood in your body, causing arterial vasoconstriction. It can also cause your heart to have some more inotropic effect, so increased contractility, increased heart rate. Amiodarone is a really bizarre drug that is very complicated. I would just know that it affects the cardiac conduction system. It affects your sodium, potassium, and your calcium channels. And you use these for either supraventricular or a ventricular arrhythmia. So supraventricular, I would think of like the atria, so like an atrial fibrillation, and a ventricular as like a ventricular fibrillation. There's 2 different dosing for these, a dead dose or a live dose. Live dose, you would give over a period of time, 150 milligrams, followed by an infusion. And a dead dose is 300 milligrams, just straight push. Lidocaine is kind of moving out of favor, but I went ahead and included it because it was kind of mentioned in the book. You would use it for the treatment of ventricular arrhythmias, but they have found that amiodarone is significantly better in reducing mortality as compared to lidocaine in the case of using ACLS. And that's going to block your sodium channels in the heart so that you're kind of reducing the conduction of ectopic sites. Atropine is a muscarinic antagonist, so it blocks the acetylcholine from binding to muscarinic receptors. And in particular, we're concerned about the heart when we're giving atropine, so we're blocking those receptors. So acetylcholine is going to stimulate a parasympathetic response. If you block that, you're going to get more of a sympathetic response. So it's going to increase your heart rate. You would use this in the situation of pulseless electrical activity. It's used to be used for asystole, but now they're kind of moving away from it. In reality, you're probably throwing everything at them if they're asystolic in a true code situation, so you might see it used anyway. So this goes back to the H's and T's. Why do we even have the patient having a cardiac arrest at this point anyway? Do they have an arrhythmia? going down the pathway of the defibrillation and cardioversion. Did they have a heart attack? Well, it might be a different plan of course. Maybe they need to go to the cardiac cath lab. Maybe they need to have open heart surgery. Is it because of a failed airway? A respiratory arrest can quickly turn into a cardiac arrest, especially in a pediatric patient. That's actually, my first code was a pediatric patient that had a respiratory arrest and went into a cardiac arrest. She actually did really well. I was really impressed. Are they just needing blood? Maybe they don't have any blood in their body and they need some blood cells. One that I wanted to mention was a cardiac arrest due to a regional anesthetic. So if you were to have a high amount of local anesthetic in your body, creating a toxic level, it could produce seizures, it could produce like a total spinal blockade, and one of the treatment, other than supporting, so supporting would be like putting an endotracheal tube in, chest compressions if they don't have a pulse, but it's a lipid infusion. And it's a 1.5 milliliters per kilogram initial dose. This is on your other sheet too, on your cheat sheet, so don't feel like you have to write it down right now. Followed by a 0.25 milliliters per kilogram per minute infusion for about 60 minutes. And you can repeat doses if need to. But they have found that this has significantly decreased the mortality involved with having local anesthetic toxicity. Anaphylaxis, we'll go into more detail in a little bit. That's a whole other chapter. But most important, think about airway because of airway swelling and epinephrine as your first two treatments. So now we have a stable patient. We're thinking about getting them to the ICU. And you guys are making sure that there's airway equipment, RT is there, and that there's a monitoring equipment to get there. So another pop quiz. You've been called to bring equipment for a code in labor and delivery, and the patient has had a toxic amount of local anesthetic. You should consider immediately providing exactly. You want to provide that lipid emulsion. All right, guys. You doing okay?
Yeah.
Sweet. So operating room fire. I feel like this has become a big deal at Mission recently in the prevention of. We're looking at two different injury mechanisms, either thermal burns or smoke inhalation. A thermal burn would be more evident. A smoke inhalation might be, you might not realize how bad their airway looks until it starts swelling really bad and you lose the airway. You're looking at fire triangle, so you have to have an ignition source, an oxidizer, and fuel. Those are kind of the three big things with this. And I included here what are different ignition sources, fuels, and oxidizers. Oxidizers I thought was kind of interesting. Oxygen and nitrous oxide are both considered to be oxidizers. Fuels could be an endotracheal tube. It could be hair, it could be alcohol, so like prep on the face. Ignition sources could be, cautery, lasers, ECT equipment, just malfunctioning electrical equipment, a defibrillator. All of these things could potentially cause a spark. So what are we going to do to prevent a fire? Well, limiting oxygen. If you're doing a surgery at the ASC and it's on the face, they're probably going to be, and it's a MAC, they're not going to have any oxygen on their face. You're going to allow them to pre-oxygenate, but then as soon as that local's in there, you're going to take it away because that's a fire risk right there. Using a laser tube during laser surgery would be really important. And then sometimes I've heard that a fire was started because one of the residents had put their, I can't think of the word right now, but like a fiber optic light on a drape, and it caused a hole, like it burned a hole in the drape, just because of the heat from the light source. So RACE, I think you guys have probably seen this before, but rescue, alarm, contain, and evacuate or extinguish. I think that's something that would be a good test question, probably. Types of fires, we're looking at an airway fire first. Maybe because you have a laser in the airway, maybe it's a tonsillectomy or an adenoidectomy or a trach. I know whenever I've done a TNA out at the ASC, we try to reduce our FiO2 to 30% if possible. So if you do have an airway fire, you want to stop the oxygen, disconnect the breathing circuit, turning off the oxygen from the machine. Take out the endotracheal tube as quickly as possible. Even if you think that you controlled it with some saline, you need to get that out of there. Pouring saline or water into the airway to reduce any flames that may be there. And then once you're sure that the airway is secure, there's no longer a fire threat, putting a new endotracheal tube in, because there will be swelling there and you will lose the airway. A surgical fire is going to directly involve the patient. That's going to be like an ignition of the surgical drape, like I talked about, or a laser, ECT equipment, maybe a fire on their face. One thing that you want to avoid is just having a nasal cannula under a drape, because that can just build up and build up and build up oxygen, and one little spark can cause a fire. Again, high risk. Anything that's above the xiphoid is considered high risk for a fire in terms of surgical procedures. You want to use a carbon dioxide extinguisher once all your other steps have been taken. And that was something that I felt like was really highlighted from the book, was using the CO2 extinguisher. So that's something I would really just make a mental note. And something to think about is I feel like with the NIST exam in particular, I'm studying for my boards right now also, so I totally know how you guys feel trying to study for this really crazy exam. But I feel like they're really going to hit on safety features. And so if you see something that looks like it's a safety issue, that might be something that you might want to pay a little bit more attention to. So like the carbon dioxide extinguisher, I think that stuff would be more important than necessarily knowing like your receptors for your drugs. So an OR fire doesn't necessarily involve the patient, and it's not in the airway. So it needs to be quickly contained, but luckily the patient is fine at this point. Firing the facility, you're going to need to either halt operations, close all the fire doors, potentially evacuate the building. So your role, make sure that you're ready to transport anesthetized patients either to the ICU if they did have some sort of airway fire. You might have to be the one to find the oxygen shut off to the room if it's a real problem, if it's a fire in a specific operating room and they can't get it under control. Bringing the CO2 fire extinguisher, the recommended extinguisher type. And they did note that fire blankets might actually make a problem worse than actually helping the situation. So I would avoid the fire blankets and go straight for the extinguisher. Pop quiz. There's a fire in the OR. You've been called to help. On the way, you grab You want to grab the CO2 extinguisher, exactly. All right, malignant hyperthermia. Very rare, incredibly rare. However, very, very deadly, potentially life-threatening if unrecognized. I think this is really interesting that mortality in the past used to be about 80% if you had malignant hyperthermia, and now it's down to about 5%. And that's because of recognition, calling the MH hotline, which I'll give the number in a bit, and dantrolene. So malignant hyperthermia is an autosomal dominant disorder. It's a mutated ryanodine receptor on your chromosome 19. I don't know how important that is, but that was in the book, so I included it. What I think is more important is that you have this excess release of calcium. Calcium is going to be the thing that's what causes your muscles to contract, is calcium. And so if you have a flood of calcium in your muscles, you're going to have huge rigidity, your muscles are going into overdrive. And so we call it like this hypermetabolic state because your muscles are working really, really, really hard because of all of this calcium. So it's the calcium that's really the problem on a ryanodine receptor that's been mutated on chromosome 19 and it's autosomal dominant, which means it's an inherited disorder. Really, the thing to take home for that is that it's inherited. So if someone in your family had it, it's possible that you might have it too. Like I said, it's this hypermetabolic state. You have really increased consumption of oxygen, ATP, which is a fancy way to say energy, resulting in cellular damage. So all of your muscle cells are breaking down, releasing this thing called myoglobin, which gets stuck in your renal tubules. So it's going to cause renal damage, which is why you might see some brown in your urine. You have an elevated potassium because when your cell bursts, it releases a lot of potassium. Detrimental changes can occur very quickly. And there's no way to really know if a patient has MH or not until they have it. So you want to try and prevent. Are we getting the patient's anesthetic record? Are we asking them if their family's ever had history of it? And they could have had anesthesia before and still have an MH event, which I thought was really interesting. And it can occur at any point. It could occur early on in the general anesthetic. It could occur when they're in the recovery room. It could occur hours later when they're back at home. So your triggering agents, you only have one muscle relaxant that's going to cause it. That's succinylcholine. And then all of your inhaled general anesthetics, desflurane, isoflurane, and sevoflurane. And the other ones are more historical. Something I thought was interesting that's not on there is nitrous oxide. So the things that are not on there, they're also part of these groups. If you think about your muscle relaxants, your non-depolarizing muscle relaxants like rocuronium and becuronium are not on there, and nitrous oxide is also not on there. Your first clinical presentation sign that you might have a problem is that your end-tidal CO2 level is going to be increasing steadily. You're looking at, like down here at the very bottom of the screen, it builds up, it's going to keep on building up. Dramatically, we're already up to 80 within 4 breaths. So we went from 40 to 80 within 4 breaths, and that is actually fairly accurate. You may notice that they have total body rigidity or a masseter muscle spasm, which is the spasm right here of the jaw, so they might not be able to even open their mouth. Maybe they're really tachycardic. Tachycardia is the earliest sign, but the earliest specific sign is the increasing end-tidal CO2. If you're noticing increased body temperature and that's your first sign, then you've missed it because that's one of the later presentations, even though we call it malignant hyperthermia. So, which electrolyte is responsible for the muscle contraction during malignant hyperthermia crisis? Calcium, exactly. Perfect. So lab findings, elevated end-tidal CO2. If you learn anything from this, elevated end-tidal CO2. Elevated potassium levels because all of those cells are breaking open because they're all in overdrive. So you have the elevated potassium levels, you have myoglobin because of the breakdown of muscle cells, and they might go into DIC if you're not taking care of them appropriately, or even if you are taking care of them appropriately. All of these agents are susceptible to causing a malignant hyperthermic crisis except nitrous oxide. Like I said before, succinylcholine is the only muscle relaxant that's going to cause it. Desflurane, isoflurane, and sevoflurane are also going to cause. So we have a patient that is actually having a malignant hyperthermic crisis. What are we going to do? Well, we're going to stop the anesthetic gases. If it's succinylcholine, we're not going to give it again. We're going to give 100% oxygen, which means either you're going to increase your flows on the anesthesia machine, or pop them off and go straight to an ambient bag if possible. Because volatile gas can still be present in the machines for like another 20 minutes or so. You're going to give them propofol if they're cardiac stable, and dantrolene is really the game changer here. You want to measure their temperature, obviously. So dantrolene is one of the most complicated drugs to ever put together. If you have an 80-kilogram patient, which is pretty average, your initial dose, which is 2.5 milligrams per kilogram, would be 200 milligrams. That would require 10 vials. Each vial must have 60 milliliters of sterile water in each one. And so you're looking at, not only is that a huge amount of fluid to try and put together, but time consuming. And this is a huge emergency, and now we need to make dantrolene, which is a pain. You have to continue it for another 36 hours afterwards, but it's considered the only antidote for treating MH, and it's really, I think, the big game changer of why our mortality has gone from 80% down to 5%. There is a newer drug out that's dantrolene, but it's made by another company, and it only requires 1 vial, but it's very expensive right now. I think that over time that's what we're going to be seeing, because it's really expensive for places to have at least 10 vials available at any point in time, and they expire. So it's a very...
They have to be in all different areas of the hospital.
I don't know how many... Like, in Mission, you're right, there probably would have to be in a couple different places, but like at the ASC, they probably just have one source.
Yeah.
But it's a huge cost savings for places like, you know, small surgery center, like a plastic center, that they don't want to buy the dantrolene. They might not even have any of these triggering agents there, which, so they don't have to buy the dantrolene, and you don't have to go through all these MH protocols. It makes it kind of interesting, but I've heard of some people not having like succinylcholine even in their place of work because they don't want to have any MH risk. So what else are we going to do? We're going to actively cool them. We're going to lavage their stomach. They might need heartline so we can get some ABGs and see how high their potassium is. And a bladder catheter is just a core temperature that we can look at. They're going to have to go to the ICU for monitoring because it could occur again, and we're going to continue the dantrolene. It can occur in 25% of patients, is what I said. So let's say they are at the ASC. What are we going to do? Well, we're going to have to get them to a main hospital where they can get treatment. But we don't want to move them until they're stable. So you're still starting the dantrolene. You're making sure that they're not going to crash in the ambulance. And you're trying to get their end-tidal CO2 as close to normal as possible. There's 2 different ways to test for MH, and this is why we don't test patients for MH. The first is a muscle biopsy contracture test, which is the most sensitive and specific, also known as a caffeine halothane contracture test. All this really means is that you need a little piece of muscle, and you have to be at a center, a specific center that can test MH. There are only 4 in the entire United States. So they have to have anesthesia to have a muscle contracture test. So if you're worried about them having MH, why would you put them under anesthesia to find out if they have MH? I think that's kind of a weird roundabout way of looking at it. So it doesn't happen very often. It's very expensive, and there's only 4 in the entire United States. The other thing that you can do is a genetic test, blood sample. But it only is going to detect 30% of all of MH patients. And I think the take home of this is why we don't test people. This is why we go more by family, because it's an inherited disease, because it's on the autosomal dominant disorder on the ryanodine mutated receptor on chromosome 19. So who's susceptible? You want to just go ahead and take out the volatile agents from the machine. You want to remove the succinylcholine from the room. Remove temptation. If you don't have it in there, you can't use it. Tivas are fine. Propofol is fine. Etomidate is fine. Regional is fine. And they don't recommend giving dantrolene unless you actually have an MH crisis. What are we going to do to prepare an anesthesia machine for this? You're going to use high flow oxygen, 10 liters per minute through the machine, especially with the ventilator cycling, making sure the vaporizer's out of the room. And I would say don't necessarily memorize guidelines specific for each machine, because each machine is different. Each machine has different guidelines.
We're not changing the soda sorbs?
That's exactly it. I think that you should, but it didn't say in the book to do that. You would. In reality, you would do that because
we still do.
Yeah. But each machine now has like specific guidelines. I think removing those would be a really smart thing to do. And then if you do have a case of MH or you think they might have MH, you can always call this number. It's 24/7, and they're really helpful. They'll walk you through trying to diagnose if they do have MH and how to treat it and what to do. Anaphylaxis. So anaphylaxis is a severe allergic reaction. Just to differentiate between an allergic reaction and an adverse drug reaction, an allergic reaction can occur from any drug, any sort of chemical substance that the body is exposed to. Whereas an adverse drug reaction is, we know that it is a reaction of the drug itself. Morphine is going to cause itching and nausea. That is a perfect example of an adverse drug reaction, while latex could cause an allergic reaction just from exposure to it. The allergic drug reaction is going to involve your immune system. So anaphylaxis, an immune reaction to the drug or a foreign substance. We don't know when it's going to occur. It's unpredictable. We don't see it coming necessarily unless we know that they have a history of it, and it can be potentially life-threatening. So an allergic reaction, you have these proteins in your body called antibodies. And when you have a foreign body that goes into your system, whether it's hay fever or an anaphylactic reaction to latex, you're going to have this inflammatory cascade response that's going to blow out of proportion. And so you could have a skin rash, hemodynamic instability, bronchospasm, cardiac depression, airway compromise. And this is a pretty good picture as to what exactly is an allergic reaction. Notice here that I said IgE. IgE is an anaphylaxis, and we'll go into what anaphylactoid is in a little bit. Just kind of, I know the difference enough to pick out which one is your bigger problem. The problem that we're talking about now is anaphylaxis. So you have this antigen. Your B cell, which is part of your immune system, is recognizing that there's this antigen. Antigen is a fancy way of saying a foreign body. Your B cells can produce these IgE antibodies, which bind to the surface of mast cells or basophils, which are other immune bodies. That's the first time you're exposed to it. So then nothing really happens. The second time that you're exposed to it, same antigen, foreign body, going to bind with this mast cell or basophil that has these same IgE receptors that were made the last time by this B cell. They're all bound on the outside of this either basophil or mast cell, and it's going to cause the release of all of these chemotactic factors, or histamine, or tryptase, causing your blood vessels to become really engorged, leaky. You're going to have inflammation and a lot of swelling. Anaphylactoid is different than anaphylaxis in that it does not involve IgE antibodies. That was the difference. It can also happen the first time that you have exposure to a foreign body. Unlike anaphylaxis, where the first time nothing may happen, it's the second time that you really want to be careful. Not that you would know that it's coming, but the first time that you're exposed would not cause anaphylaxis. The second time would. So you have airway edema, you have vascular permeability, vasodilation, lots of mucus, muscle spasms causing bronchospasms. An awake patient is going to be a lot easier to diagnose this in. They're going to have difficulty breathing. They're going to tell you they feel really weird. I feel dizzy. I feel this impending doom. The anesthetized patient is going to be more complicated to diagnose. They can't tell you that they feel bad. You might notice that their heart rate starts getting a little faster or a little slower. You might notice that their blood pressure drops. It might be a slow drop. You might notice that they have a bronchospasm. But let's say it's a procedure that you can't even see the patient during the procedure. You might have no idea that they're red head to toe and having this huge anaphylactic reaction. So triggers usually occur about 10 minutes after the drug is given. Most common drug that we give in the perioperative setting that causes anaphylaxis is muscle relaxants, which was news to me when I learned it. I always had thought that antibiotics would be your highest cause, or latex, because we're so worried about latex products, but really it's muscle relaxants that have the highest incidence of anaphylactic reactions. Lots of other things could cause it. Like I said before, any agent, any drug, any exposure to any chemical substance could potentially cause an anaphylactic reaction. So a common trigger during anesthesia causing an anaphylactic reaction includes E, muscle relaxants. So what are we going to do? We're going to stop giving whatever it is that's causing the reaction, which sometimes is really difficult to determine what that was anyway. We're going to give them 100% oxygen. We're going to, if they don't have an endotracheal tube, we're going to put an ET tube in. We're going to give them epinephrine. This is going to stabilize the mast cells. It's going to treat your hypotension. It's going to treat your bronchospasm. And it's going to prevent further mast cell degranulation. So the number one drug to go to is epinephrine. You're going to want to give volume because now all of the volume that was in your capillaries and your blood is now in your tissue because they're swelling so badly. And this is what's causing the hypotension. You could give vasopressin instead of the epinephrine, but epinephrine is really the gold standard. Antihistamines, which won't stop the production of histamine, it will just block the receptors. And giving steroids and maybe a bronchodilator like albuterol. This was something that I learned when I was making this PowerPoint. I had never heard of this before, but they recommend to measure your serum tryptase level, which is one of those chemotactic factors that's released by the basophils and the mast cells, 30 minutes to 2 hours after you've had an anaphylactic reaction. And this confirms mast cell degranulation. So again, this is the test that's going to differentiate, was this an anaphylactic reaction or an anaphylactoid reaction? What are we going to do differently for treating anaphylaxis versus anaphylactoid? Nothing. They have the same exact treatment plan. So, in an anaphylactic reaction, histamine and tryptase are released by, it's a bit of a trick one, so.
That was a lot to remember.
I know.
Is it E?
It is E, exactly. It is mast cells and basophils. Those are the two immune system components that you could, if you had to make any choices, if you had no idea what it was talking about, you can eliminate liver and alveoli because this is an immune reaction, and we know that basophils and mast cells are part of an immune reaction. This is our last topic, guys, so we're almost done, okay? Massive hemorrhage. We've lost blood. Very life-threatening. We might know this is coming because we're doing a cardiac procedure, we're doing a AAA. Any surgery in the chest is considered to be a high risk for blood loss. Certain patient populations, do they have liver disease? So they're not able to make clotting factors. Livers are the ones that are responsible for making clotting factors. Are they on an anticoagulant like warfarin, heparin? Are their platelets not working? Do they just not have enough platelets? And maybe they just aren't eating well, and so they don't have enough proteins in their body to even make all these clotting factors. More challenging is the unanticipated massive hemorrhage situation. A trauma patient that rolls in at 2 in the morning that you had 10 minutes to prepare for. An accidental vascular surgery like a lap chole gone wrong. And these are challenging because you don't have your equipment, you don't have supplies, you might not even have staff for it. Whereas for a cardiac procedure, you know that there's going to be blood loss and you're going to manage that appropriately. So another pop quiz. You have a higher suspicion of massive hemorrhage occurring with these patients, except Yep, C. See, you don't need to worry about taking this. You're going to do great.
Oh, no, you'll ask us the right questions.
So we can eliminate these other options. The trauma victim with end-stage liver disease, we know that's going to have high blood loss, is a trauma victim, and their liver isn't working. We know that if it's going to be a tumor resection around an organ, you have higher incidence of blood loss. A patient taking Coumadin, higher incidence of blood loss. So that's perfect, lap chole. That's going to be your lowest incident there. So I think this is morally your bread and butter here. This is something that I always go to you guys because you guys know how to use a level 1 transfuser. You guys know where all this equipment is. And you guys are on top of this. You know this. You want to establish IV access. You've lost blood. You want to give blood. You want to replace your volume with either crystalloid, with colloids, or blood products. Something important to note that you guys have all really taught me is that when you're giving blood products, you don't want to mix it with LR. You want to mix it with plasma light or normal saline. You want to try and gain control of the hemorrhage, so you want a surgeon. What are we going to do? Do they have an airway? They need an airway, most likely. Do they have good IV access, or did they come with a 24 gauge right here in their AC from the ER? So we're going to put in IV catheters, or we're going to put in a central line. IO access, intraosseous access, is something that I learned from more like the ACLS and PALS. I've only seen it used a couple of times. I've never seen it in the operating room, but as like an EMS first line, they couldn't gain any IV access, so they went straight to an intraosseous. And what they'll do is they have like a gun. It looks like a gun, and they put it to, I can't get my leg all the way up there, but they'll take it to your tibial bone, and they'll put it right up against the tibial bone, and it's like a drill, and you drill in. Not really pleasant for the awake patient, but for someone that you can't get IV access, it works beautifully. It actually runs really well. It goes straight to the bone. It actually redistributes really quickly too. I was really surprised. That was a really cool invention.
How do you stabilize that?
A lot of tape. You just kind of cross it over on the top like this. And it's not something that you would keep in for a long period of time because infection to the bone is really, really bad. But it works really well for a very short period of time. So pressurizing fluids, getting the level 1 out. The things to really watch out for is making sure there's no air in it. And I feel like you guys are the people that I go to when I'm like, hey, I have this machine that I have no idea how to use, and you guys know how to put it together already. Just as a side note, I think that you guys are really the ones who have taught me about equipment and about all of the monitors and how to use all of this. And so since that's the bulk of your exam, I think you guys are going to do really well on it. So just keep that in mind. You guys know this stuff. You're the experts. I come to you for this stuff, so you can do it. Obviously, the bigger the IV, the better it's going to run. A central line is not necessarily going to be as well to run fluids in as a 14-gauge IV. But some of the disadvantages of using a peripheral IV, like is it going to infiltrate, or someone could easily pull it out, removing the patient. Benefits of having a central venous access: you can give fluids, you can give vasoactive drugs without worrying about extravasation. You can get a CVP going. IJ is the most common on the right side, just because you can use an ultrasound and it's easy to access, versus the subclavian, which is more technically difficult, and the femoral line, which is a little bit more dangerous. What are we going to do to set up? Well, it's a sterile procedure, so we need all these sterile equipments. I think most importantly, you're going to position the head away, and you're going to put them in some Trendelenburg to engorge those venous vascular beds. A cordis might be the best way if you just need to give a lot of fluid, just put a cordis in. So what fluids are we getting? We're giving crystalloid, like I said before, normal saline, LR, or plasma light are the big three. Those are all isotonic solutions. Again, no blood products with LR. You need to have 2 licensed witnesses for giving blood products. Blood products could include blood, FFP, which has to be thawed, so it takes at least 30 minutes, containing your clotting factors, platelets, which are really delicate, so you have to use just a single IV infusion line. It's not something that you can put through a pump. And I didn't include it on here, but cryo, which is, again, more clotting factors. The rapid infuser, there's either the Belmont, which is the one that I use in the ICU, or level 1, which is the one that I've seen used out here. It's going to warm the fluid, which is really important. A trauma patient is already hypothermic. A hypothermic trauma patient is potentially a dead trauma patient. That's something that's really important, why we keep the room at 100 degrees, it feels like. And you can set the rate. You can set it pretty high. 750 milliliters a minute is as high as it could run. Autologous blood transfusion means that you're giving their blood back to them. So this might be cell saver during a case that we know there's going to be a lot of blood loss, so we've seen it coming and we have this set up. Or maybe we know that they're going to have some problems, and so the patient came in 3 weeks ago to give their own blood and will receive that blood again during a surgery, which I don't see very often now. But in the heart tower, at the very beginning of the case, they'll take 2 units off of the patient, and then at the end of the case, they'll give that blood back. So that's the same thing as an autologous blood transfusion. And it's just washing and spinning the extracted blood cells to give back to the patient. In a massive hemorrhage, we also want to, we're going to get tons of lab work. Feels like every 5 minutes you're going to get lab work, and eventually we're going to transfer them to the ICU. So we want to make sure that they're stable. But these patients with a massive hemorrhage and you're using the massive transfusion protocol, they have very high mortality rates. So our very last pop quiz. Which of these fluids and blood products are required during resuscitation of a patient with massive blood loss? All of the above, exactly. So I wanted to take time to say thank you to all of you. I know from the first day that I was in clinical until my last day of clinical, which is tomorrow, you guys have been the reason that I feel like I've gotten through it a lot of days. Where is this? How do I use this machine? Or where am I? Have been a lot of my questions, and I feel like you guys have really helped me along. I even know that there are some days that I would not have made it with a CRNA, and you've been the ones to tell me, like, oh, you should go with this CRNA, or you need to do this, have this set up and this ready to go, and then you'll have no problems. And so you guys have really been really amazing.
We're glad to help you.
Thank you. Do you guys have any questions at all?
I want to be that place right there.
I wouldn't mind going there either. Thank you, guys.
All right, well, thank you. We got one more next week.
Oh, do you? What's that one on?
I don't know. I don't have that sheet that showed who was doing what and when.
I don't have it with me right now.
Yeah.
I'm sorry, I went really fast. I know that's a lot of
Oh, no,
material,
that
but
was fine.
That was good.
I think that this stuff is really, this is not the thing to spend your time on. Do the cheat sheet that I gave you.
Okay.
Use that. Spend your time on other stuff, equipment, spend your time on that. There's only 5 questions from this, so I don't think that this is the most important thing to really focus on.
Well, it's a lot of, it's not like reading that chapter. I keep going back about that heart.
The heart
chapter
chapter.
7. Oh my gosh, that is so crazy.
I read through a lot of the book, and I have to say I agree. I was reading it and going, I didn't know that. I don't know this.